result, he lost his position in Vienna and was excommunicated from Vienna to a rural hospital in Hungary, which is maybe like going from here to Edmonton, who knows? Or McMurray, is that the place? Okay. So in 1865, he suffered a nervous breakdown and was committed to an asylum, and then died 14 days later from wounds caused by beatings that he sustained at the hands of the guards. And he was, and for all of that, he was 47 years old. So by the time he was 47 years old, he was dead. And you wonder why he became increasingly outspoken. Why didn't he just suck it up and say, the hell with it, nobody's listening to me, I'll get on with my life. So that brings up the next topic, which is moral injury. What the hell is moral injury? Anybody know what? People probably know what who Semmelweis was, but anybody know what moral injury is supposed to be? I first heard about this on NPR, and they were interviewing somebody, a veteran. And moral injury is a term that's now been developed, refers to trauma that occurs when one's sense of moral rightness is violated by a trusted authority or individual. So it has to be somebody that you trusted now violates what you think is the right thing to do. And the term was originally thought up to try to address the gap between the diagnosis of PTSD and what happened with the Vietnam's vets when they came back. So the Vietnam veterans had trusted the United States. They had signed up. They were going to fight the just war, and then they came back and they were pilloried by the protests. And then they felt like they had trusted the government, and now they were had done these things. And so it wasn't even combat related, which was the thing. Like, come on, guys, suck it up. Just get on with life. And so, but they had a hard time doing that. And they'd walk in front of trains and a variety of things. It came up again when this was what brought this up, was that the U.S. veterans in the Afghanistan war were thought to sustain moral injury because they couldn't get the U.S. government to rescue the interpreters. So when the U.S. pulled out of Afghanistan, they left these guys who had worked for the United States in Afghanistan and wouldn't get them back to the U.S. And they ended up being killed by the Taliban because they had supported the U.S. while they were in Afghanistan. And so the veterans who felt a moral obligation to these guys because they worked with them were really upset. And if you had a sense of right and wrong, it would bother you more than if you were, like working on Wall Street and just a power person. So anyway, so since that concept has been evolved, this concept of moral injury can appear in many domains, including healthcare. And moral injury in healthcare can come from being forced to operate a high-stakes environment without needed resources by a trusted authority. So, for example, I can remember having nurses working in an intensive care unit and having 2 or 3 times the number of patients they were supposed to have, and then not being really able to take care of the patients, and then having what was called burnout. So what is burnout really? It's not that you're tired, it's that you feel like your ability to do the right thing has been compromised, and most importantly, by an authoritative figure. And you can imagine that it's very common in terms of rape, particularly if someone is known and trusted. So, for example, if it's familial rape, that would be very devastating because you trusted the person and then they violated you. So how does that relate to Semmelweis? And the question with Semmelweis is, was he a madman to begin with, or was he driven mad by moral injury? So you can imagine if you were Semmelweis and you cared about people and you cared about life, and you couldn't convince people to wash their freaking hands, and people were dying, right? Women were dying willy-nilly because of your inability to convince people. It would be devastating if you had any sense of moral. And so it was interesting. It brought up that question about Semmelweis. Was he just a madman who happened to figure out that you needed to wash your hands? Or did something happen to him as a result of his inability to influence people to do what was save lives and prevent kids from being orphans and things like that. So now we'll get on to the talk, which is about using interventional techniques in device implantation. And not surprisingly, applying interventional techniques to the device implantation has a sense that this is the wrong thing to do. You shouldn't be doing this. And so we'll talk a little bit about fibroplasty. And this is a very common occurrence where you see when you go to you want to add a lead here, which is no big deal, except that there seems to be subclavian occlusion. And so when people see this, that what they tend to do is, wait for it, they either try to stick under the clavicle to get beyond the occlusion. They abandon that side and go to the other side, put in a whole new system, 2 incisions, increased risk of infection. They can do extraction where they obliterate the fibrous tissue that's developed around the lead, either using rotator or some sort of a rotating grinder. And then once they have access, they can reimplant. And the device companies love that because it's a very big ticket item. Or you can try to get through that and then do fibroplasty. And so it turns out that the occlusion is frequently not nearly as bad as it looks. And you can see here, this looks like it's hopeless. But if you obtain access to the occlusion, peripheral to the occlusion, and then inject contrast through a small catheter located close to the occlusion, what you'll find out is a lot of times what looked totally hopeless is actually relatively easy to cross. And so in here, we're just using a standard 035 glide wire, and we're getting a wire through the occlusion. All of which would be to no avail if you couldn't do something about the obstruction that you found here. And so that brings up the topic of now what do you do? And it turns out that once you get through, if you do get through, you can dilate it. And we call this fibroplasty rather than venoplasty. If you use the term venoplasty in this setting, it raises the specter of a vein. It raises the idea that you're going to rip the vein open, which seems like makes sense that you rip the vein open because veins are these very fragile structures, and that you would end up causing terrible trouble. The patient's going to bleed to death and you shouldn't do it. But the point is that it's really not a vein anymore. What happens is when you put wires into a vein, you get an aggressive fibrous reaction around the leads, and in effect, the vein's been replaced by fibrous tissue. And so when it turns out that the rules and tools of atherosclerotic vascular disease really don't apply to situations of fibrous tissue. The closest is the fistula. If you have a fistula with a lot of fibrous tissue, that's close to it. But so what you need for fibrous tissue is very different than what you need for atherosclerosis. And so what we did is started doing fibroplasty, and back in 2000, more or less, we gave up using progressively larger dilators, and we had a series of 373 patients, and we had no clinical outcomes, adverse clinical outcomes, including the learning curve. And it took 13 minutes to cross and dilate the obstruction. So it's a time-effective process with no outcomes. Now, all of you who are cardiologists, especially interventional cardiologists, know that the risk of complications is in the early stages. So if you're learning how to do angioplasty, if you're learning how to do whatever interventional procedure, you're most likely to incur, if complications can occur, during the initial bunch of cases that you do. So that's the learning curve. And so interestingly, this includes our learning curve, which said to me that there really wasn't any potential for adverse outcomes, because this is a bunch of guys who'd never done this before. And yet, despite that, despite doing this many cases, there were no adverse outcomes. So if you compare what the standard, which is to use progressively larger dilators. Palma, who's a physician from New York who came to learn how to do this and took it back to Montefiore in New York City. There were several physicians who followed his lead, usually younger guys, and then there were the older guys who continued with what they were up to. And what he was able to do was compare the group of patients where the physician had a subclavian occlusion and was capable of doing venoplasty, fibroplasty, versus the group that did not embrace that technique. And he found that it reduced implant time by an hour compared to the traditional approach. It also reduced the likelihood of failure. So what does that mean exactly? Well, that means that the guys who did this found a subclavian occlusion, and their intent was to add a lead, usually a BIV, add an LV lead. And then they found the occlusion and decided, nah, the patient didn't really need it. So the likelihood of being successful went from 0 if you did fibroplasty to 25%. Seemed like pretty compelling. And then just this year, now 2 years, I guess, the Mayo Clinic in Rochester and Paul Friedman compared tunneling, which is the other alternative. So you have a subclavian occlusion. One of the options is to say, okay, well, I'm just going to go to the other side. I'll get access on the right side, and then I'll put the lead in from there, and then I'll tunnel across the sternum and then connect it up to the device. And that's a very popular approach for people who are afraid to do fibroplasty. And at the Mayo Clinic, people sort of do things the way they want. And there's a group of people who embraced fibroplasty and a group who didn't. So they were able to compare, and they found that by doing fibroplasty, it reduced procedure time by 40 minutes. But importantly, it also reduced acute complications. So you're less likely to have complications with fibroplasty than you were with tunneling. And the reason for that is that when you tunnel, especially on somebody who's taking anticoagulants, you end up with big hematomas and that sort of thing. So it turns out that tunneling, when compared to fibroplasty, was not such a great idea. Despite that, I can tell you that particularly in the United States, the likelihood, despite the data that I just showed you, the likelihood that physicians use fibroplasty is probably one center out of 10 at best, and which raises the possibility, what the heck is wrong with me? Why can't I get people to see this? What am I saying wrong? How am I doing it? Did I smile enough? What is wrong with me that makes it not possible to help people understand the importance of this? When you're doing this, it's important to optimize the process. And one of the things that I found was that you really need, if you're going to be doing these things, you really need to have the necessary equipment in the room. And I was fortunate working in Lancaster that the staff actually made a cart like this for me, because I knew how ridiculous it was for me to ask for something and then have to leave the room, open the door, spend 5 minutes waiting for something. And every time you open the door, it increases the risk of infection every minute that so they actually made up a cart like this for me to have everything in place. And the other thing is to pay attention to the basics of venous access. And it's amazing the number of times people try to find the subclavian vein in somebody who's in NPO since midnight and is dry as a bone and has a negative central venous pressure, and you're trying to get access into the subclavian, which is flat as a board, because there's no vein in it. It's like trying to start an IV without using a tourniquet. So you really need to pay attention to how you're getting venous access. The other thing that turns out to be important in this is the position of the table. If you work, when you're doing a regular pacemaker, you can work like this because you don't have any long wires or catheters. But as soon as you start doing things like fibroplasty or putting in an LV lead or even doing conduction system pacing, if you're working like this, you have a 90-degree angle here. And so there's a tendency for catheters to kink, and torque control is reduced dramatically. So you've created a barrier to proper catheter manipulation if you work like this. On the other hand, and plus, catheters, things tend to fall off the table. And after you've been doing this for a couple hours and something falls off the table, there's a tendency to say, did it really fall off the table? And do I really want to start over again? So there's a tendency to have sort of a denial. But if you turn the table perpendicular to the patient, then things fall onto the table rather than off the table. And there's no 90-degree angle here. So anything you try to do to advance, whether it's conduction system pacing or whether it's venoplasty, fibroplasty, or an LV lead, everything, or extraction, everything goes straight. So it really facilitates the implant procedure. And having this table, again, the staff in Lancaster made this for me. And it used to be custom, but now it's available as a non-custom item. And this is the way it would look. So you'd be working perpendicular. So you could stand right here and your feet with the pedals could be here, and you could work in and out without having to turn backwards. And the catheters tend to fall on the table, and you can rotate the camera RAO without banging into the legs. But for most cases, it's important because you can have the fluoro pedals in a position that's helpful. We'll skip over the balloon basics when I give this talk for interventional, or when I give this talk for interventional EP doctors. They're not usually familiar with balloons, but it's just important to understand that there are different types of balloons that are mounted on a catheter. And that when you inflate a balloon for the first time, it's not like a swan balloon, but it's more like a beach ball. That once you take a beach ball and take it out of its wrappings and inflate it, it doesn't wrap itself back up the way it was. And so the same thing applies with interventional balloons. And so you can see here's one that's been deflated. And this is the term that's used for this is winging, which means that the material of the balloon does not go back, and it increases the outside diameter, makes it more difficult to get through the occlusion. When you're doing this, it's important to get access as far peripheral to the occlusion as possible. If you try to get access right here using the over the rib routine, you end up entering right at the site of occlusion, and then that messes things up and you can't get through. So it turns out that if you go caudal RAO, you can actually see that the vein isn't really where you think it is in terms of the lung. But the vein is actually in that part of the heart, or that part of the chest is actually there. So by going caudal, you can see that it's actually safe to stick out here because the lung's back here. And so by going caudal 30 degrees, you can end up hitting the vein more peripheral without fear of collapsing the lung. And it really is important for getting through these occlusions that you do that. And just an example of a caudal versus an AP venogram. So here it is. Here's the caudal version of that same one. And you can see now that there's really no lung under there. And this is the cephalic vein and as a landmark. So using caudal to get your initial access makes it easier to get access without fear of collapsing the lung. Once you get access, then we just use a stiffened micropuncture wire and advance gently. So here's the occlusion here, and you don't want to bugger this up. You want to be respectful of it, and so you're just going to gently advance this micropuncture catheter up to the site of occlusion, and not try to force the wire. And once you get to there, then you can put in your microcatheter and do an ejection. And as we saw previously, when you inject at the site of occlusion, now you see that there's an opening. And so if you're able to get a wire through, it looks like you pretty much are able to get a wire through that. And sometimes the wire that you're using really doesn't want to cooperate. It wants to go where it wants to go. And you can see here that if you didn't have an alternative, you'd say, okay, well, I got in, but I can't get through the occlusion, so that's the end of that. It turns out that if you use a small catheter like this. This is an angled hydrophilic catheter, and you use that, you have much better control over where things go. It gives you infinitely more control of the direction of the catheter than you get with the wire. So this is a short hydrophilic catheter, and because of the CME things, I can't tell you what the name of it is. But once you get it in there, now watch what you can do is that instead of the glide wire that you couldn't get to go where you wanted to go, you're able to use this catheter to advance into the area where the occlusion is, and then puff contrast or not, and then to see that you're actually safe in the vein where you want to be. Now, this violates another rule. In addition to it being heresy to dilate a vein, which is not, the common knowledge, the common wisdom in the interventional world, and particularly in EP groups, is that you never should advance a catheter unless it goes over a wire. And there couldn't be anything further from the truth. But nonetheless, that would probably take 100 years to get through. But it turns out that by using a catheter, you have better control, and you know where you are by comparison to a wire where you have no clue where the wire is. All you can see is it's sort of generally going in the direction that you want. Now, we mentioned before about the balloon getting larger as you dilate. What we learned from our experience was that there's often a second stenosis. And we learned this because we would do a dilatation of the proximal stenosis, and there'd be high fives all around, and we'd say, okay, let's put the lead in, right? And then we get out here and we'd find out there's another obstruction out here and the catheter wouldn't go. We could get the wire through here, but we couldn't get the catheter to go. So we found the second obstruction. Then we tried to get the balloon to go back here. And when you know it, the balloon was now bigger. It wouldn't go through the occlusion. So we had to get a new balloon. So we realized that if we're going to do this, we really should do our first dilatation out here at the innominate SVC junction. And so this is just an example of how you do that. You start with the first inflation at the innominate SVC junction. And if there's no occlusion, that's fine. And you can just gently, again, it's important not to do this with any force because you could denude the endothelium, I suppose. You can gently withdraw the balloon until the point where the occlusion is, then deflate the balloon and reinflate it. So rather than spending a lot of time doing head to tail overlaps the whole way back, you can just bring the balloon back. And then once you dilate the first one, you want to do a head to tail overlap all the way back because you really don't know where the occlusions are. And you can see here, there's the primary offending occlusion. And then you want to do your final inflation so that the tail of the balloon is visible in the pocket of the device. And again, when I showed you our initial data, we had 2 failures. And we were afraid to do this initially because we thought the patient would bleed to death. But it turns out that there's oftentimes a second or a really tight stenosis right in here that even though you've dilated all the way down, you still can't get your catheters in because of this occlusion. So when you do this, it's best to do the final dilatation with a tail of the balloon in the pocket. And that always causes consternation. So this is just an example of when the wire goes down easily. You can see we got the wire down, and we're using here a small balloon because it was very tight. So we're pre-dilating with a balloon that goes over an 018 wire. And then once we get that done, then we go back with our standard balloon, which is actually 9 millimeters in diameter, and goes over an Implant wire. And you can see here the residual stenosis. And the other thing that we're doing here that's worth mentioning is we're doing focused force venoplasty, which means that we're dilating or inflating this balloon against the wire that's beside it. And that enhances the effectiveness of the balloon by comparison to just dilating without the wire beside it. And people refer to that as the poor man's cutting balloon. And you can see here's another stenosis, more peripheral. Oftentimes you get a glide wire down And we learned that the glide wire frequently did not provide enough support to advance the balloon. So we have a routine where we would take a hydrophilic catheter that I introduced you to before, and we'd slide that over the glide wire down into the central circulation, and then take out the existing glide wire and exchange it for an Implant's wire, and then we can do the fibroplasty. One of the important things is even when it looks completely hopeless, okay, so here we've got access and we're injecting right at the site of occlusion. And your initial reaction is, this is completely impossible. You'll never get through this. But let's just see what happens if we put a glide wire in just for the heck of it. And there it goes. So you really can't tell, even by looking at it with a local venogram, whether you're going to get through it or not. It's amazingly perceptive as to what you can get through. If it looks like this, that looks like a very tight stenosis. And again, we tried to get a wire to go, and you can see this little beak here. We tried to get a wire to go, the wire just wouldn't go where it wanted to, so we were using this hydrophilic catheter attached to an injection system that one of the techs in Lancaster set up for me one day. This is very important because it allows you to inject contrast, and you have a hemostatic valve with a Y adapter, and so once you get where you want to go, you can put a wire through it or not, as the case may be. And you have a rotating hemostatic valve that gives you really good control over the catheter. So the wire won't go. So what we're adding our hydrophilic catheter. We're taking the wire out, importantly, and now we have control of the catheter, and you can do things that you would never be able to do with a wire alone. And we're going to use that to advance. And if you're ever concerned that you're not where you want to be, you can always just inject a little contrast. And if you're not where you want to be, you get a stain. And if you're where you want to be, you can see that you're in the venous structures. So you can see here that we're having reflux back there, and then you can work this catheter along the lead, because you have the lead to follow, and just keep going until you get to the innominate SVC junction. And then we usually try to get a wire to go out here, and then exchange, like I showed you, from the wire that we had in there, which turned out to be an 018 wire instead of an 035, and then do fibroplasty. So this is just an example of access. Again, using a stiffened micropuncture rather than a regular micropuncture is very helpful because of the fibrous tissue. If you try to use a regular micropuncture kit in this situation, oftentimes what you do is you can't get the microcatheter. You get access, you get the wire in, but the catheter, micropuncture catheter, won't advance over the dilator that it comes with because it's very soft, and then you end up with bent wires and bent catheters. But if you use a stiffened micropuncture kit, you're able to get through the fibrous tissue. And so that's what we're doing here. You can see we're using the catheter. We're going to follow the catheter up to the point where the wire is. And now this is an 018 wire, which is nice because you can inject around the wire if you like. And we're advancing the wire. And then we're going to follow that to some degree with this hydrophilic angled catheter, and then we're able to get through. One of the things is that we talked about people using wires by themselves, and that's sort of being the gold standard. And this is a case where the fellow was doing the case, and there was an occlusion, and he advanced the micropuncture wire as far as it would go. And then when he took a picture, you saw this. And it turns out that the micropuncture wire had gone astray and caused this sort of dissection here. And what the nice thing about using the small catheter is that you can follow along and follow the lead and stay away from that area, whereas you couldn't do that with a wire. And so using a small catheter instead of relying on a wire turns out to be very helpful in these situations. just to give you an example of how powerful this can be, this is a fellow who's got a functioning dialysis fistula on the right side, or excuse me, on the left side, and he had an occluded fistula on the left side, and he needed a device. So if you really don't want to put the device in on the same side as the current fistula, because it would reduce the venous return. So you'd like to use the left side, or you'd like to use the right side if you possibly could, but it turns out that it was completely occluded. And so this is a catheter coming up from below, looking for a way to get this way, but it was completely occluded. And so by using, again, we're using this small catheter to work our way through the occlusion. And the whole while you're doing this, you want to be sure that you're actually in the circulation and not in some place you don't want to be. And the nice part about using a small catheter is you can inject contrast and see that you're really where you want to be. And then we get to this point, we can advance a wire down into the central circulation, and then take the small catheter down there. Again, it's hydrophilic, is very important, so that it will slide over the wire. And then you can use the small catheter to take a picture to be sure that you're actually in the atrium, and then dilate it. And for this patient, it was a great advance to be able to do this, because now he's got a functioning system on a side that was not usable, and we didn't have to do it from the other side. So there's just a few of these examples. You can add RF energy to this. So sometimes you get this situation where you can see that there's an opening. Here's the occlusion right here, and you just can't get a wire to go through, but it's only just that far away. And so what do? There's a variety of things you can do. In this case, we're using it's called a power wire, which is a radio frequency catheter. The intervention, or the electrophysiologists use this, something like this, for crossing the interatrial septum to do pulmonary vein isolation. This is not that catheter. This is just a very straight floppy catheter. And with one pulse, 1 second long, and advancing, you can see the tip of the catheter was through. You want to check to make sure it's actually in the vein. Yep, it's in the vein, so that's good. So now we can put the wire through and then dilate that. So you can add RF energy to this. You can use, in my early experience, I used a 0.9 millimeter laser. This is back in the days when patients would have recurrent stenosis before stents, and they would put a laser, the same laser that people use for extraction. You just change the catheter, and it's 0.9 millimeters in diameter. And you can achieve the same sort of a thing with a laser to get through these occlusions. The problem with the laser is, at the time, there was no catheter that allowed you to direct it. The good part about the laser was it had an open lumen, so that once you lased a little bit, you could check your position by putting out a wire and see that the wire went down into the central circulation. So these are just some more advanced things that can be done. Long way here. Now, the other thing is, if you're really intent on getting access, and you don't have access, and you can't get access, here's a fella where we couldn't get in from above. If you go from the femoral and you can get into the vein this direction, then you can oftentimes find your way through the occlusion. Again, what we're doing here is using a catheter, an angled catheter rather than a wire, and you can get places you'd never get otherwise, because you can see where you're going, and then we're able to get access and do fibroplasty. And that's actually a balloon rupturing. One of the questions is, what happens if the balloon ruptures? And it turns out nothing bad happens to the vein. You can see this is where we had a very small wire to get through. So there's actually a coronary balloon, and the balloon ruptures when we try to do this. Now, this doesn't hurt the vein, which is not really a vein, it's all the fibrous tissue. The only potential complication is that if this remains very tight and this is all fragmented here, it can be difficult to get the balloon back out over the wire. So you prefer not to have the balloon rupture. But the worst case scenario is that it makes it difficult to get the balloon to come out. Now you can see we dilated that. Like, again, coming from below. Another way that you can use fibroplasty is using the wire under the insulation technique. So if you have a pacing lead that's mobile, you can unscrew it. Let's say it's a year or two old, but it moves. You can withdraw the pacing lead to this point, and then put a wire under the insulation, and then re-advance the wire. That's what we did here. So now we have an angioplasty wire in the circulation. Once you get the angioplasty wire in circulation, you can follow it with your small catheter, exchange to an Implant's wire, and then do fibroplasty. So that's an example. The other thing that you can do is what I refer to as the retained wire techniques, where you're gonna use the existing lead for access, and under those circumstances, the typical one, if you have an LV lead, you can put a wire in the center of the LV lead, pull the LV lead out. If it's only like a year or so, and then you have access, but which won't do you any good unless you put a balloon over it and dilate it. Another way to do it is to use a wire in the stylet lumen if it's really stuck. So this is an example. I was trying to get through the occlusion and I couldn't. The lady had developed cardiomyopathy, had a dual chamber pacemaker. We were going to put in an ICD lead. Couldn't get through the occlusion. You can see that we're not where we want to be. So we unscrewed the RV lead and brought it back to here, and then used a micropuncture catheter, a micropuncture needle to put an angioplasty wire under the insulation, like just as it's shown here. And once you get the wire under the insulation, if you use a wire that's very small in diameter and hydrophilic, the likelihood is that you'll be able to re-advance this into the circulation. If you use an 035 wire or a non-hydrophilic wire, then the bulk of re-advancing is too large. So you can see here, we've put the stylet back into the lead and we're advancing the lead, and here's the wire being carried into the central circulation. Now we're going to advance the lead down and pull the wire back a little bit. And you can see that now we have access with a wire. We take out the RV lead, and all of this would be to no avail if you were going to use progressively larger dilators. But if you do fibroplasty, then this represents an access that wouldn't be possible without bringing the patient back for extraction or some other more aggressive term. This is just LV lead using it. We talked about that. The other way you can use this is illustrated in this case, where the patient needs a new atrial lead and has a total occlusion here, and we couldn't get through the occlusion. So this is the break in the lead that necessitated the new lead, and this is the atrial wire. It's been in for, I think, 5 years, and you can see there's the breach in the insulation. So when it's in a circumstance like this, you can cut that off. You can put an angioplasty wire all the way to the tip of the lead, and then you come from below and you grab the tip of the lead, because this was too tight to re-advance. I couldn't re-advance it. So we come up with a snare and grab the lead from below. And when you do that, you grab the wire that's inside the lumen. And so you pull this down. And when you do that, and you look at what's going on the other end, you actually are pulling the lead in and pulling the wire into the central circulation. And now you have body floss where the wire goes in here and comes out the femoral. And this is what it looked like with the lead. And now once you have that wire in place, then you can dilate. And again, because this was very tight, we started off with a low profile 018 balloon. So this is an 018 wire on the outside. This is an 018 wire in the balloon, and we're dilating, and you can see the stenosis. And then we went back with a 9mm balloon, and we're able to dilate that and then give the person a new lead without having to bring them back for extraction. And remember, every time you bring a patient back for something, it increases the risk of infection. Coming back is one of the highest risks that you can do for these things, and risk of infection if you brought the patient back to extract the lead as opposed to doing this type of procedure. So it's very helpful. And you could actually do this with defibrillator leads. This lead's a year old, and it brings up the issue of why shouldn't you extract if you, and it turned out that the patient had a bad ICD lead, and the decision was made to extract the bad ICD lead a year ago. And in the process of extracting the bad ICD lead, what happened is they killed the LV lead, which is not an uncommon event. So now we have no LV lead, and the patient, they said, well, let's just see how she does. She did pretty bad. Her EF dropped by 20 points and she went into heart failure. So they decided they needed to get access again and now add a new LV lead. And so this is occluded up here. What you can do, the lead's only a year old. We put a wire all the way to the tip. You can snare it from below and pull down. And this again pulls the pacing, it pulls the wire into the central circulation. And then once you get the wire through the central circulation, you can dilate and add the LV lead and put the RV lead back. And you can see here's the LV lead that was destroyed by the process of extraction. And in my opinion, an unnecessary extraction. They should have just added a lead rather than extracting because the lead that was there, adding a lead would have really caused no harm. Oh, and the other thing is, once you do extraction, it increases the risk of occlusion. So that one of the reasons people like to tout for doing extraction is that it reduces the likelihood of the vein becoming occluded because there's less stuff in the vein. It turns out that the extraction experience is very traumatic to the endothelium and whatever's there, and you end up with a higher likelihood of occlusion after extraction. This is my pedophile case. I'm always afraid when I show this, somebody's gonna come and throw me in jail or check my computer. Turns out this is actually from a magazine, the front page of a magazine with this phrase. And when I saw it, I said, boy, this is just right up my alley. So I think having the right tools can really make a huge difference in terms of what kind of care that you can provide from the patient and avoid unnecessary, more aggressive procedures. Even though it sounds dangerous, it turns out it's quite safe. And all I can say is, what's the matter with me? Why can't I convince the rest of the world? But there we are, and we can do this. Thank you very much. Anybody out there have a question? We're going to send you a quiz. Who is Semmelweis? Yeah. Got questions in here. Okay. Yeah. Absolutely, positively, its only intent is to get access, right? So the intent is not to establish patent vein. The intent is to take a vein that's already occluded and give you access, and then it goes back to being occluded. The question is, if you have a symptomatic subclavian obstruction, right? You put a lead in and now the patient has a swollen arm. What about venoplasty or fibroplasty under those circumstances? And that's a whole different topic. And people who do this, the likelihood of restenosis is extremely high under those circumstances. Why that is, I don't know exactly. Nobody knows because it's not done that commonly. One of the solutions might be to use a medicated balloon instead of a standard balloon. Again, if we're talking about using venoplasty for a symptomatic occlusion. Now, it's important to remember that if you have a symptomatic occlusion, they usually become symptomatic relatively early, right, in the process. And so the safety of the fibrous tissue hasn't been established yet. So plating a balloon in that situation where the lead's only been in there for a month, 2, 6, whatever. It's not the same animal as dilating something where the lead's been in there for 2, 5, 10 years. And after the lead's been in there for a year or so, you get the fibrous tissue, which then makes it safer. So the topic of dilatation for a symptomatic venous occlusion is an interesting one, but it really is a whole different topic, and the potential risk is unknown because it's still mostly a vein because it hasn't had a chance to develop all that fibrous tissue. What you have is clot and early development of fibrous tissue. So doing a very aggressive dilatation of a symptomatic stenosis would be very different than doing fibroplasty for chronic leads. The question for the audience out there is, do you ever use a medicated stent? The issue of using a stent in these situations is that if you have existing leads and you put a stent in to establish venous return, people have done that. They do have the non-medicated stents have a very high likelihood of restenosis. And the other concern is that you jail the leads in place. And that if you need to take let's say you do you put in a medicated stent and now you get an infection, right? How do you get the leads out? The stent's in there, it's trapping the leads in place. If you have to, for infection, you have to extract the leads, there's no question. But if you're going to try to extract the lead and it's in next to a stent, the whole risk of extracting the lead, particularly if you go from above and do a typical extraction where you bring your extraction equipment from above, is very high. Whereas if you come from below, you're able to pull the leads through the occlusion. So one of the unfortunately underutilized techniques is femoral extraction, because it's painful to grab the lead from below. It just takes forever using existing equipment, and people just don't want to do it. So femoral extraction, unlike from above, is very unpopular because of the skill set required to grab the lead from below, compared to just grabbing the lead from above and putting a big sheath over it and doing it that direction. There are some exceptions. There are some very strong proponents for femoral extraction, but again, it's not a commonly done procedure. And trying to teach fellows to do it, trying to help them learn how to grab a lead from below, it's really extremely painful. From above, you mean? We never did that. I guess most of this was just sort of done out of necessity. I guess we never found the need for it. I'm not sure that's the right answer. It may be just that we're not familiar with it and we should have used it and would have helped, but that we just using contrast and seeing that the contrast is refluxing into the vein gives you the reassurance that you're actually where you want to be, as opposed to in some other place. And not infrequently, when you're working with one of those small catheters, you may see a stain. But again, if it's in the fibrous tissue and it's all compressed and it's low pressure, it never seems to cause any issues. You just don't want to keep going and then put a big balloon in and then rip it all to pieces, right? Because then you'd be in trouble. But if you're maintain and stay along the lead, then this turns out to be extremely safe. Yeah, I got Derek Chu. Yeah. Yeah. Oh, that's good. We have no idea. I stole that picture from somebody online one day. It's just not been studied. Now, can I answer that? It looks like we have a question. And I have to ask Karen to unmute so she can ask her question. Or no, it's not Karen. It's and there's Derek Chu. There are two. So if there are twos
Derek,
out there.
You should be able to mute.
I think he has to unmute. Ask to unmute. Oh, the phone number. I'll give you my cell phone. You can call and ask me. Huh?
No.
So 717-917-8386. 717-917-8386 +1, I guess, for the international.
Derek, do you want to type? It's not allowed.
As a nurse. That moral injury. Now, maybe these are just all the people, maybe they don't, maybe they're just the people that are here. So if anybody, again, if anybody wants to ask a question, you can call my cell phone. Yeah, so now histologies. There's probably more known about the histology of a fistula, a dialysis fistula. And again, that's the situation that's the most similar to this. And that's where they use the high pressure balloons, where the balloon that we adopted, we got from interventional radiology. And one day we blew up a Mustang balloon, which is sort of the standard 20 atmosphere balloon for peripherals. And the stenosis laughed at it and stayed there and didn't do anything. And we went to interventional radiology and got this a balloon that they use for dilating fistulas goes up to 35 atmospheres. At the time it was 30. And that was able to dilate the stenosis. So it's the fibrous tissue that was causing the occlusion. We probably have to go to form consent and all the, do it as a study because
Well, you know,
right. And
expansion and stuff like that.
but every time you
And
do
then,
something,
you know, now it's become a way.
get it up to the occlusion, you could. You could put it in, before you do the dilatation, you could put it in over the wire, and if you get through the occlusion with the wire, you could you could put the IVUS in. Is it over the wire, the IVUS? So if you had some over the wire technology, you could do that before you put the balloon in and do a study. Again, whenever you're, at least in the US, whenever you do something that's not part of the standard, say, well, why did you build a patient for this IVUS catheter? Why did, and is there a billing code? And, how are you going to pay for this IVUS catheter? There's no billing code. There isn't any, one of the problems is there's a difficult billing code to do fibroplasty. There's not in the US uniform agreement in various parts of care that they're going to pay for the fibroplasty. Because they said, and the hospital says, now we got to pay for the balloon. And, if you'd done extraction, we could have billed for the extraction. What are you doing this for? We could have, we could have brought the patient back and give them a big bill for the extraction. So there's a lot goes on here that's not immediately apparent. 3D CT,
Vascular.
you always, CT, echo, MRI, whatever you use, always overestimates the stenosis. Come away thinking there's no chance. And you go in and put a wire, goes right down. So it's not, you just can't tell. And interestingly, if you're doing a right-sided, if you've heard your colleagues complain about right-sided implants, especially upgrades, right-sided upgrades are just can be absolutely horrific. And for the longest time, couldn't figure out why. The venogram looked fine, everything's great. But remember, when you come from the right side, there's a 90-degree angle. And if you have existing leads, there's always fibrous tissue. So it turns out that the reason it's so darn hard is that you combine an acute angle with some degree of stenosis, and it just makes that procedure horrific. Whereas if you don't look at the venogram and you just dilate without looking at the venogram, you'll always find a stenosis, and you'll find the rest of the procedure is like 10 times easier than it would have been if you didn't dilate in advance. So there's a whole range of situations where this is extremely helpful. Thank you very much again, everybody out there.
Yeah, thanks.